very excited that we're here today at American Heart Association Scientific Sessions 2023. This morning we had the very exciting, late-breaking clinical trial session on the SELECT trial of patients with obesity, overweight and obesity and cardiovascular disease. I'm joined today, my name is Chiadi Ndumele. I'm a Director of Obesity and Cardiometabolic Research at Johns Hopkins, and I'm also the Chair-elect of the Council on Lifestyle and Cardiometabolic Health for the American Heart Association. I'm joined today by my good friend and colleague, Dr. Tiffany Powell-Wiley, who was one of the discussants today of the SELECT trial and is also the Director of the Social Determinants and Cardiovascular Risk of Obesity Laboratory at the NHLBI. Tiffany, it's wonderful to have you here today.
Thank you so much, Chiadi. It's great to be here with you and great to talk about the SELECT trial.
Wonderful. Well, you know, it was a really exciting morning. It was a packed house, and there's obviously a lot of excitement around this study. So why don't you just, we see this top-line result of a 20% reduction in cardiovascular disease / mortality among these individuals with obesity or overweight and cardiovascular disease without diabetes. Let's talk about the clinical significance of that.
So as I mentioned during the session today, SELECT really follows a long line of trials that have looked at GLP-1 receptor agonists, and now we have the data to show us that for patients with overweight or obesity, but primarily with obesity, that we can reduce cardiovascular risk and reduce all-cause mortality, particularly for those without diabetes. And so we know from SELECT that this was an international study that looked at over 17,000 patients, was rigorously designed to look at the cardiovascular outcomes. And so we have this important data, but as I mentioned this morning, we really need to put in the context of who we will be able to treat with these medications, who will have access to these medications, and where does this fit in a more holistic approach to treating obesity?
Yeah, so I think that's really helpful. I mean, I think that there's no question that this has done a lot to help bring obesity into the conversation. Absolutely. As we're kind of thinking about a modifying risk for people with cardiovascular disease. You talk about a holistic framework. You know, you were a member of this cardiovascular kidney metabolic health initiative. Absolutely. Where obesity was front and center, and where we think about it as a driver of much of CKM syndrome. How do you contextualize SELECT within that context of thinking about this progression of disease and thinking about how we're thinking about the SELECT population in the CKM syndrome construct?
So we really need to think about who are the ideal patients that will benefit most from GLP-1 receptor agonists, especially knowing that, again, as mentioned during this morning, this wasn't a primary prevention trial. This was really about patients with cardiovascular disease but without diabetes. And so we really want to think about those patients with CKM syndrome stage 4, those who have established cardiovascular disease, who would benefit and who might need to be on GLP-1 receptor agonists.
Yeah, so it's really helpful to have a new tool to be kind of considering, knowing it has some clinical effectiveness among those patients at that extreme, that stage 4 CKM syndrome, where it's nice to have an additional option to consider. Now, I think one of the things that you mentioned at the study is that this is important, maybe even becomes frontline therapy to consider for that subset of the population. But there's not just this. There are other options to be considering as well, and you highlighted some of those at your talk.
Yeah, yes, I think when we think about treatment for obesity, we have to think about around the treatment continuum. We need to think about where does lifestyle modification fit in, and I think that fits in for all patients, regardless of whether they have cardiovascular disease or not. But then we have to think about how are we using pharmacotherapy, how are we using bariatric surgery, because there are patients who are going to benefit from any of those therapies. And so that's where it really it becomes important to think about who is getting access to pharmacotherapy, who is being referred for bariatric surgery.
Yeah, and it's a very interesting question because right now, we don't really have, I think, the best infrastructure to make sure that people have access to all of the different options. Certainly,
Absolutely.
we're under supporting behavior modification and lifestyle change.
Right.
And then the broader questions you raised about access, which we'll get more into, and then bariatric surgery. So thinking about how we're supporting a patient-centered approach seems pretty central here to kind of thinking about how we contextualize these results.
Right, I think we, in the work around CKM syndrome, we really highlighted the need for an integrated care approach. And I think for patients with obesity, but also with cardiovascular disease, we need to think about who can help in coordinating their care, because they're seeing multiple specialists. They may have an endocrinologist, they may have a cardiologist. Many patients need to see an obesity medicine specialist. And so who in that care team can really help to coordinate care? And that may be a person who actually serves as a care coordinator, who really makes sure that all of these treatments are being covered, that the specialists are aligned with making sure the patient is on the right medications at the right time.
Yeah, that's a really helpful kind of piece of a care model to be considering. Now, we're all very excited by the results. Obviously, this is landmark in terms of a trial. One of the things that was brought up was the questions of the diversity within the trial and the implications of that for generalizability. So 2 things came up. Number 1, there seemed to be an underrepresentation of women relative to their the population in the overall population that would be eligible for the SELECT trial. And there was also a pretty good representation of African Americans, but not of some other race ethnic groups. Tell me what you think about that, what that means, and what implication that has for how we move forward.
Right, so you're right in that women made up about 24% of the study population, well below what we see in other obesity treatment interventions, and especially not indicative of the rates of obesity amongst women. We also saw that while African Americans and blacks made up 12% of the population in the United States, they only made up 4% throughout the rest of the trial, representing populations throughout the world, and populations on the continent of Africa were underrepresented in particular, and especially as well as in Asia. And so I think it highlights the difficulties that we have with generalizability of many of these clinical trials that we're doing, many of these multi-center, multinational clinical trials, where the populations, diverse populations around the world are not well represented. And so, again, I think we need to think about how as we build more post hoc data around the use of GLP-1 receptor agonists, how do we look at the effects of these specific of these treatments in African Americans and black populations, in Asian populations, Hispanic populations?
Yeah, it seems like there's really going to be a need for greater intentionality.
Absolutely.
In how we approach this, because if we want this to be a population, if we want to apply this to the broader population, those individuals need to be represented in these studies.
Absolutely, and we know from obesity treatment studies already that, for instance, treatment with bariatric surgery has been shown to be less effective in African American populations. And again, black and Hispanic populations were less likely to be referred for obesity, for bariatric surgery, even with Medicaid expansion. And so intentionality is a perfect way to describe where we need to be around bringing people into clinical trials, making sure we're recruiting the right patients and the most at-risk patients, but also making sure that our clinical trials reflect the diversity of who we're taking care of.
Yeah, who we want to serve in this regard. So
Absolutely.
I think that's super important. Now, you described thinking about the broader social context for obesity, and it sounds like thinking about this in a vacuum or thinking about this just in a clinical space is not going to be sufficient for our ability to understand this problem. Can you give us a little bit more context about that?
Right. And so one thing that's happened with the advent of GLP-1 receptor agonists and how how much interest there is in people utilizing them is it really has helped us recognize how complex obesity is, and I think it has helped us really understand the social, environmental, and more psychological factors that relate to the development of obesity. And so, again, as we talked about, obesity does not exist in a vacuum. It exists related to contextual factors, where people live, what foods they have access to, what amounts of or areas that they have available for safe physical activity, and it relates to their housing and economic status, and all of those factors need to be thought of as levers for policy change that might improve rates of obesity, but also prevent obesity to begin with.
Yeah, so I imagine you might agree that when we see a challenge that maybe affects a small percentage of the population, maybe it's something that you can look at the individual level in some way. When we see a challenge of overweight and obesity that's affecting 70% of the population, then that seems to be someplace where we need to think more systemically and systematically about what may be contributing.
Right. I think we know that there are systems in place, systems that exist that drive what we're seeing from a global obesity epidemic. We know, for instance, a food environment that relates to what types of food people have access to, the climate change that's affecting what types of foods can be grown. That is playing a huge role in driving obesity rates around the world. Yeah. And so we need to couple what we're doing with pharmacotherapy with policy changes that really target those systems.
That's very helpful. And then now when we talk about these multi-level social determinants of health, one of the things that's really important is you highlighted in your talk that the individuals, so this burden is not carried equally in the population.
Absolutely.
And there are some groups that are more affected as a result of more adverse social determinants of health. On top of that, some of those groups are the groups that are least likely to be able to get access to support in multiple ways for managing obesity, or more broadly managing a healthy lifestyle. Can you give us some thoughts about that?
Right. We know, for instance, that African American women bear a significant burden in terms of the rates of overweight and obesity in the United States, and yet there's data to show that African Americans are less likely to be referred for bariatric surgery. We're less likely to receive treatment with GLP-1 receptor agonists even before the SELECT trial results. And so there's a multitude of factors that relate to this disproportionate burden of obesity in populations that are most impacted by adverse social determinants. And again, it gets back to those areas related to social need, related to access to housing, related to access to economic resources, access to food, and areas for physical activity. All of those play a key role in which populations are most impacted. But we are doing much more work in really understanding what interventions work for the highest risk populations. And so I think that's what I wanted to highlight this morning, is that we know that there's some things that work, and so we need to think about how do we put resources towards those interventions.
Yeah, so I think here we're now seeming to cover a spectrum here, and from a public health standpoint, we know it was highlighted how much premature mortality, how much healthcare expenditures we see related to obesity, but there's multiple levels. We're talking about people who are coming into the pipeline and developing obesity. We're talking about obesity itself. We're talking about those downstream consequences of obesity. In SELECT, we have people who already have cardiovascular disease, and we're talking about those tools, but it seems like we need to be thinking about all these various aspects. The prevention component, the just addressing obesity before it's led to end organ injury, and those individuals who are at that side of the spectrum. So it can't be a one solution problem here that we're thinking about.
Absolutely. This is a complex issue that requires very multifaceted, multi-level intervention. And so I was recently at a talk where one of the speakers focused on the need for coupling prevention and treatment for obesity. You can't disentangle the two, just like you can't disentangle policy intervention from more treatment related to pharmacotherapy, lifestyle intervention, bariatric surgery.
Yeah, and then also talking about disentangling, there's the other component, which is obesity itself is closely entangled with so many of the other things that we treat,
Absolutely.
like diabetes and high blood pressure and dyslipidemias. So talk to me about that piece. Should we be thinking about that as separate, or do we really need to be thinking collectively about the adiposity as well as these other cardiometabolic comorbidities that go along with that?
Right. I think one of the great points that came out of this morning was the idea that that obesity is a cardiovascular risk factor that we need to treat, and it fits in line with hyperlipidemia, with diabetes, and it relates to and in many ways can precede these other risk factors. And so I think that's what the beauty of the CKM syndrome framework and really thinking about CKM health is that we're thinking more holistically about how do we take care of patients that start with, where we start with thinking about life's essential 8 and risk related to more prevention, and then we move into how do we think about patients who develop risk factors over time and ultimately cardiovascular disease. But we always need to think about starting with prevention.
Yeah, that's really helpful. So now, in terms of addressing obesity, one of the big challenges right now is that the know-how in clinical environments is limited.
Absolutely.
And training for obesity is not really a core part of most of our curricula. And you, I think, highlighted the fact that there's a lot of weight bias and stigma within clinical environments that is often tied to a lack of understanding of this complexity and understanding of even how to approach this with our patients.
Right.
What's the mandate from that standpoint?
So there certainly is a need for educating clinicians to better understand what the biologic underpinnings are for obesity, but again, better understand the complex and multi-level factors that relate to the development of obesity. And so that type of education can start in medical school, but it is something that is required throughout medical training for residents, for as a part of continuing medical education for physicians. And I'm really excited to see that there now not only board certified obesity specialists, but there are many cardiologists who are actually going back to do training in obesity medicine so that they have that dual board certification to really care for patients with obesity and cardiovascular disease.
Yeah, it's so remarkable. Right now, this is not a scenario where it's just for the obesity medicine specialist. It's the cardiologist who needs to be thinking about obesity, who needs to be thinking about the endocrine, who needs to be thinking about the kidney protection. Like, we actually need to be collectively considering all these various elements for patients. Now, let me actually ask you a broader question around access. So for access, where are we from that standpoint? We are not currently, patients have a lot of questions around, can I even get these therapies? Certainly those with more social determinants, more adverse social determinants of health. So how much of a challenge is that?
So we know, of course, that it's a huge challenge in terms of even accessing many of these medications. Right now, we know, of course, that there are actually shortages for things like semaglutide. And so that's where really thinking about, again, this treatment continuum for obesity, because it's not going to be just the medication that people need. They're going to need access as well to lifestyle interventions and, if needed, bariatric surgery. But access is a huge issue, and not just access to medications, but also access to endocrinologists for treatment and prescribing some of these medications.
Yeah, so there really needs to be some wholesale change. Sounds like we certainly need to be thinking about the policy implications of this to make sure we're supporting access, but again, contextualizing this in the broader spectrum of opportunities we have for our patients. Last question I want to ask you is around thinking about going back to that number, that 70% number we're talking about. How likely can we just medically treat our way out of all of this? Is that something that's actually likely, or do we need to be having a much more a broader view of how we address this as a population?
No, we certainly cannot use medications to get treat obesity and get ourselves to a healthier state from a population standpoint. We really, again, need to think about how do we take these multi-level approaches in addressing the obesity epidemic. How do we address policies related to built environment, to the food environment? How do we couple that with greater access to treatments for patients?
Wonderful. Well, I mean, at the end of the day, we have a very, very exciting trial. We have an amazing landmark breakthrough here for patients with obesity and cardiovascular disease. But we need to contextualize this in the context of the broader set of treatment solutions, and then also thinking upstream about the prevention of obesity, about preventing complications related to obesity, holistic care, social determinants and access. So a lot to think about, but a lot of exciting science to build upon.
Absolutely, there's a lot of work to be done, but it's exciting to bring together so many specialists, but also bring investigators across different areas of medicine and social and behavioral science to really work on this really complex area.
Well, thank you so much for being here today and joining this conversation.
All right, thank you so much.